next topic is by Ruwani PERERA. He's Senior Registrar, National Eye Hospital. She's going to talk about imaging and diagnostic modalities for ischemic optic neuropathy.
Yes. Thank you, sir. My topic is imaging and diagnostic modalities of ischemic optic neuropathy. Ischemic optic neuropathy is a diagnostic involved in the combination of the clinical evaluation, serological test, and the visual field testing, histology, and the imaging modalities like MRI, OCT, and ultrasound. As we all know, it is very important to exclude arthritic variety of the ischemic optic neuropathy, as it is a life-threatening and a vision-threatening cause, unless if we do not start corticosteroids immediately. And clinical evaluation and the history, thorough clinical history, including the onset, duration, and the nature of the vision loss is must, and associated symptoms like pain and fever. Those can help to differentiate between the different types of ischemic optic neuropathy. And ophthalmological examination, including the visual acuity and the color vision, in optic neuritis, the color vision is more affected than the visual acuity. And the visual field testing, in ischemic type of optic neuropathy, we can commonly see in the inferior altitudinal field defect. And fundoscopy, in the first picture you can see the pallid disc edema in arthritic type of ischemic optic neuropathy. In the second picture is a non-arthritic type hyperemic disc edema, and the pupillary assessment to see afferent pupillary defect. And the diagnostic modalities, including the ES, erythrocyte sedimentation rate, it usually we can identify the inflammation, which is a key feature of the arthritic type of ischemic optic neuropathy. Usually it exceeds 100 millimeters per hour. It is usually normal in non-arthritic type. And C-reactive protein, which is elevated and more sensitive than the ESR in diagnosing giant cell arthritis. And the changes in C-reactive protein levels are useful for monitoring the disease activity as well as the response to the treatment. Only 4% of biopsy-proven giant cell arthritis have normal values of C-reactive protein and ESR. And the full blood count to exclude the underlying conditions that might contribute into the ischemia, and to identify thrombosis. We have to evaluate the other vascular risk factors like blood pressure, lipid profile, blood glucose, and questions to exclude sleep apnea, and the intake of phosphodiesterase 5 inhibitors because it will accelerate the nocturnal hypertension, and interferon alpha, which deposits the immune complexes within the optic nerve, optic disc circulation, and the history of amiodarone intake. And if the patient is less than 50 or there's a history suggestive of that, you have to exclude homocystinemia. And the imaging modalities, CT scan can be used to assess the orbits and the brain for the structural abnormalities, but it is less sensitive than MRI for identified soft tissues and evaluation of ischemic optic neuropathy. And MRI of the orbits with contrast and the fat suppression can differentiate ischemic optic neuropathy from optic neuritis and the compressive lesions like optic nerve sheath meningioma and the orbital masses. And also diffusion weighted imaging and the post-contrast enhancement. In some few studies suggest small series of patients with NAION. Unlike patients with optic neuritis who had abnormal MRI in the 97% of cases, patients with NAION only had an abnormal scan in 17%. And the more white matter abnormalities in patients with NAION suggesting that it is more likely in the setting of diffuse cerebrovascular small vessel disease. And also the eyes with NAION have more white matter hyperintensities, lower optic nerve volume, and magnetization transfer ratio of chiasma than controls, likely reflecting axonal loss and the demyelination. In MRI, we can differentiate NAION from optic neuritis as I previously mentioned, and identifying arthritic from non-arthritic anti-ischemic optic neuropathy. And there's a central bright spot sign a potential new MRI imaging sign, that's a central bright spot sign, may aid in the early diagnosis of anterior ischemic optic neuropathy due to GCA, and also diffusion weighted imaging and the post contrast enhancement. A little bit about fluorescein angiography used to assess the blood vessels in the retina and the choroid to help to differentiate between arthritic from the non-arthritic anterior ischemic optic neuropathy. As we all know, there's a delayed choroidal filling in arthritic type. And other imagings are the ocular plethysmography, can measure measure the blood flow in the optic nerve, and Doppler ultrasound to helpful in diagnosing anterior ischemic arthritic type of ischemic optic neuropathy. Little bit about the temporal artery Doppler ultrasound. It is a valuable tool in the diagnosis and management of arthritic anterior ischemic optic neuropathy, a condition associated with GCA, and it's a inflammatory condition affecting the blood vessels, particularly in the head and neck. It visualizes the temporal artery and shows the characteristic findings like the halo sign. You can see the halo sign around the red spot, and stenosis and the occlusion, lack of compressibility. And it's very, it has high sensitivity and the specificity and importance in early diagnosis and treatment. And temporal artery, even though the temporal artery biopsy is the gold standard for diagnosing giant cell arthritis, we can use Doppler ultrasound for the as an adjunctive investigations, especially in the cases with biopsy is not feasible or when a rapid diagnosis is needed. And the European League Against Rheumatism recommends the use of ultrasound as the first imaging option for the diagnosis of GCA. In optical coherence tomography is a non-invasive imaging and provides high resolution imaging of the retina and the optic disc to assess the optic nerve head edema and the monitor disease progression. OCT angiography also visualizes the microvasculature of the retina and the optic nerve head, and it helps to diagnose and monitor in the ischemic optic neuropathy. And the quantitative ocular imaging like OCT, stratus OCT, scanning laser polarimetry, and the confocal scanning laser ophthalmoscopy also used to qualitatively measure the peripapillary RNFL thickness, optic disc morphology, and the ganglion cell loss after swelling of the optic disc has resolved. And HRT, that is confocal scanning, to evaluate the excavation of the optic nerve after episode of AION. You can see in this picture, in the first two pictures, there's the HRT. The right eye, after 6 months after the non-arthritic type of ischemic optic neuropathy, there's no much difference between the right and left optic nerves. But in the right side pictures, in the arthritic type of optic neuropathy, you can see in the right eye there's a more excavation few months after the disease. In this picture also, the timely excavation of the optic nerve you can see in the HRT, and the fundoscopy also you can see the excavation. In temporal artery biopsy should always to be done to rule out the arthritic type of ischemic optic neuropathy. The elevation of the ESR and CRP also sensitive but not specific for the GCA. So the temporal artery biopsy is gold standard. You have to do it under local anesthesia with the combination of local anesthetic and the epinephrine, and you have to take the minimum of 2 centimeters and to avoid skip lesions. And in the histology you can see the granulomatous inflammation involved in the internal elastic lamina. And biopsies may occasionally yield false positives, prompting the use of non-invasive techniques like MRI and Doppler ultrasound. So other investigations are the electrophysiology, both in non-arthritic and the arthritic. In arthritic and non-arthritic ischemic optic neuropathy shows the amplitude reduction and the in the pattern VEP and the flash VEP. With demyelination, we can see delayed latency as well as reduced amplitude in the involved and also in the uninvolved eye. Eye is commonly abnormal. So the other tests are the polysomnography to identify sleep apnea and blood clotting test if there's a suspicion of clotting disorders, and all of these investigations have advantages and limitations. So the combination of these methods are often used to comprehensively evaluate the optic nerve. And the recent advances in the optic nerve imaging are the high resolution imaging and 3D construction, artificial intelligence and machine learning, functional MRIs, and the advanced OCT, and the portable and accessible imaging devices. And the future directions are the integration of nanotechnology, advanced AI and deep learning, and molecular imaging and biomarkers, and non-invasive functional imaging, telemedicine and personalized medicine, and hybrid imaging systems. Thank you.
Thank you, Ruwani.